I'm Dr. Ryan, and this is the Mental Dental Institute.
That's a wrap on the first ever Mental Dental Institute, but it won't be the last. For future courses, stay tuned.
Hey, everybody. Welcome to what is our first live class edition of the Mental Dental Academy, free on YouTube. I'm, of course, Dr. Ryan. Thanks so much for joining us today. What we'll do is just have basically a casual run through of what one of our live classes look like. And if you are an Academy member and you're signed up for the Mental Dental Academy, you've seen this case before. If not, this is your first time seeing this case. And how these live classes work is they're very active and engaging. So I want you guys to post lots of comments as I ask questions so we can get some back and forth going. Of course, we won't have the ability to hear from you. In the Mental Dental Academy, we do a virtual classroom where I can talk with you actually using your microphone and my microphone. Here on YouTube, we have to do kind of typing in comments. I'll address those comments with you guys live. So please post some comments. Let me know how you're doing and where you're watching from, just to get started here. I'm sure we have people all over the world tuning in. So you can let us know, post a comment where you're watching from, either in the US or elsewhere. And as we go through the case and I ask you questions, it'll be a great time to participate as well. What we do in these live classes, again, is I present a patient case. Sometimes it's a research paper that we kind of dissect together. This one will be a patient, and it's set up just like the case-based scenarios that you would see on the INBDE or the ADAT. And so essentially, I give you a patient case, a patient box with information, critical information about the patient. And then I'll also sometimes provide some pictures, just like the board exam would. Usually the pictures are not the highest quality. If you've taken the board exam, you know this. But I'll give you some pictures as well. They'll probably be a little higher quality than what you'll see on the board exam. And then we'll go through some practice questions together on that patient case. Hey, Najma, it's good to see you here. You may have seen this case before. This is an earlier one from earlier this year. So maybe, again, if you've watched all of my recordings in the Academy, you've seen this one before. In case you decide to join the Academy later, right now we've already had over 20, I think it's 24 classes so far. So if you join the Academy, let's say tonight, you'll have access to all of those previous classes. So don't worry, no fear of missing out here. But it's always better to attend in person, because you get to test yourself live and kind of go along with other classmates, so to speak. So I think that's enough of that. Let's dive into the case tonight. And I'm going to throw this up on the screen here. As you can see, this was from earlier this year. What we'll do is I'll keep this slide up for a little bit of time so you guys can look at the case. Again, this is straight from one of my live classes on the Mental Dental Academy. So feel free to take a look at the patient box and the images, and then after this, we'll go through the practice questions. Ferris, thank you for commenting. Can't wait to join the Academy. I would love to have you join. Will it be good enough to study for the board exam? Absolutely. Yes, it will. This is really designed to be That's a cool profile picture, by the way. It's designed to be all encompassing, and it's the only platform where you're going to have this opportunity to talk with me live and do these practice questions in this way. So I also throw in some tips and tricks as we go through these live classes. As you guys know, I like to do memory tips and make things easier to remember. So yes, this is designed to be an all-encompassing platform with practice questions and new videos and lots of cool things to look forward to. That being said, we'll also do another one of these live in the Academy tomorrow night. We usually do every other Tuesday at 7 p.m. Eastern Time. So if you join the Academy today, you would have access to another one tomorrow. Hey, Arpita, good evening. And you'll have to let us know if you're the, because we do have an Arpita in our Academy. So maybe you are that person. Lindsay joining from Virginia. Thanks for being here. Welcome in. All right, guys, I'll leave this one up for a little bit longer, and then I'll get to the first question because we have some people coming in. This is fun. This is the first time I've done this live on YouTube. We already have over 50 people. All right. That's who I thought it was. Thanks for joining, Arpita. You may have seen this case as well. We have a lot of Academy members here. It's great to see you guys. We have a hardworking bunch of students in that Academy. That's for sure. That's why we have so many people pass. Our pass rate is so good for the Academy students. So you guys are making me look good. All right, that's enough of this. We're going to go to the next slide here. This is the first question for this case. What craniofacial condition was this patient most likely born with? And since this isn't the Academy, usually I'll throw up a question and you can actually select your answer A, B, C, and D anonymously, and then we talk about it. Since we're not on the Academy and we're on YouTube, I'll need you guys to write a comment in the comments there, in the live comments, with A, B, C, or D, and share with everybody what you think the answer is. And let's see if anyone is brave enough to answer. Don't worry, there's no grading here. This is a judgment-free zone on YouTube. But if you have an idea, or if you don't have an idea, just guess A, B, C, or D. What craniofacial condition was this patient most likely born with? All right, we have one vote for C, hemifacial hypertrophy. Thanks, Ferris. Thanks for answering. Lindsay says B, Treacher-Collins syndrome. All right, we have a couple more C's. We have Priyanshi Patel, Gularmina, Ambi, Dr. Sarita, My Choice Dentist, Isabella. We have some D's, I see. All right, great job, everybody. We have some good answers here. C, D, I see a lot of C's and D's right now. I don't see any A's, which is good. We could probably rule out Pierre-Robin sequence. Good. Okay, so we have a couple of answers here, and this is great. Well, what we'll do, and with these patient case-based scenarios, you always want to go back to the information presented in this patient box over to the left. And we're told in the patient box that there is significant asymmetry observed on the left side of the face, including the mandible and the ear. You guys can see that in the current findings section down here. Let's see here. Okay. And we can also see in the initial CBCT, see the patient had surgery here. Before surgery, there's a significant deviation of the mandible to the patient's left. So the question becomes, is the right side too big or the left side too small? What do you guys think? Let me know in the comments. Do you think for this patient before surgery, is the right side too big or the left side too small? And my big hint here would be look at the ramus height. Okay, so we have some votes, right side too big, left side too small. Very good. Good job, everybody. Thanks for participating. It makes this a lot more fun. So that's one thing to look at. Oh, and Dr. Sarita just pointed out exactly what I was going to ask next. Left side too small because of the left ear involvement. That's absolutely right. So you guys can see also in the current findings that the left side has an ear issue going on here. Left side of the face, including the mandible and the ear. So that's a big sign. So we know if maybe the right side's too big, we're not sure. The left side's too small, not sure. Well, we're told the left ear is also involved. Okay, looks like we have a bunch of votes here. Thanks, guys, for participating. Left side too small, left side's too small, baby. Hey, baby, thanks for being here. Left side too small, left side too small, right side too big. Yeah, so if we kind of include all of this information together, we can decide pretty confidently that what's going on here is actually not hemifacial hypertrophy, which is one side's too big. It's actually hemifacial microsomia, one side's too small. And so with hemifacial microsomia, we see what's called asymmetric microtia, where you have a small ear on the affected side. So that alone, this one word here, and ear, gives away that this is a hemifacial microsomia. The other two answers, by the way, A and B, we can rule out because they don't have anything to do with asymmetry. They have more to do with either a very retrusive mandible or a retrusive mandible we call mandibulofacial dysostosis in the case of Treacher-Collins syndrome. But the other two do have something to do with asymmetry. So we'd think C or D. D is the answer here, and the ear gives it away. I talk about guessing correctly in the Mental Dental Academy as well. I have a video dedicated to that topic. And so if you were able to get down to either C or D, guessing is a great principle if you're not sure which one to guess. And so when in doubt, this is a Dr. Ryan suggestion. It's not necessarily a rule that I want you to live by, but it's a suggestion. If you're in doubt, if you've ruled down to two possible answer choices, take the one that's more common. Take the condition that's more common. If they're asking you what's the most likely diagnosis, for example, take the condition that's more common. Hemifacial microsomia is the second most common congenital anomaly of the face. It's very, very common. So if you're ever in doubt, pick the one that's the most common. By the way, does anyone know the most common congenital anomaly of the face? Does anyone want to share that information? You guys can say in the comments. Very good, Dr. Sarita. Yes, cleft lip and palate. That is the most common congenital anomaly of the face. Very good. I talked about Pierre-Robin sequence too. And as you guys can tell, I asked six of these practice questions on the case, but in the Mental Dental Academy, in these live classes, I like to ask a lot of questions. So we're not actually just doing 6. I'm asking a lot more than this to keep you thinking. What's the sequence of Pierre-Robin sequence? It's called a sequence, which means it's essentially a line of dominoes that hit each other and fall in a specific order. So something happens, it causes something else to happen, which causes something else to happen. What are those things in Pierre-Robin sequence? Does anyone know? I'll give you guys a moment in the chat. Okay, Rahima says big tongue. The tongue is certainly an issue. So you're right. It's big relative to the lower jaw. Dr. Sarita, micronathia, glossoptosis, and cleft palate and airway obstruction. Very good. Okay, so between the two of you, good teamwork there, Rahima and Dr. Sarita. You're absolutely right. Essentially, if I were to put this in order, how I think of it with the dominoes, the first one is micronathia, a small mandible. This causes the tongue, and this is very, very early in development, guys. So this is very early on in development. You have a small mandible. It causes the tongue to kind of fall backwards towards the throat. We call that glossoptosis. So the tongue falls backward. As the palate is closing, again, very early in development here, we get a cleft of the palate because the tongue is kind of backing up in the way of the palatal shelves fusing. So you get that cleft palate, and then that can lead to other issues like airway obstruction, for example. So that's what Pierre-Robin sequence is. Definitely want to know that for the board exam. Want to know all of these for the board exam. But again, the first answer to this first question is D, hemifacial microsomia. Let's go to the second one. Which of the following surgical procedures did this patient undergo? Our options are Lefort osteotomy, bisagittal split osteotomy, Lefort and bisagittal split osteotomy, and genioplasty. And if you guys ever want me to go back to the first slide with the patient box and everything, I can. Probably want to see that for this question. Of course, you guys can interact with me in the chat and let me know if you need to see anything or if you have any questions about anything we're talking about. I see a yes, so we'll go there. Thanks, Omar. So which surgery did this patient undergo? Look at the before, look at the after, and consider that this patient has a hemifacial microsomia. The options are Lefort only, a bisagittal split osteotomy, or BSSO only, a Lefort and a BSSO, or a genioplasty. All right, so we have a B, a D, several C's. Okay. So we have Arpita with a C, Priyanshi C, Ten Pasang C, Omar B, Emma C, Guillermina B. We need to rotate the occlusion. Well, that's for sure. We definitely need to do something. Somebody mentioned before about the occlusal cant, which is a great observation there. The cant is a right to left kind of offset of the occlusal plane. So there's definitely some canting going on here. The maxilla and the mandible both being affected. Aura says A, Yamali says B, Lindsay says B, Viviana and Molek say C. Great job participating, everybody. And remember, this is a judgment-free zone. So even if you're wrong, you're right because you're participating. So going back to this second question here, which of the following surgical procedures did this patient undergo? Well, we can talk first. If I were to get this question, I would just want to kind of stay clear in my mind what jaws each of these things are affecting. So the Lefort osteotomy involves surgical separation of the maxilla from the rest of the skull. Bisagittal split osteotomy involves cutting the mandible at each ramus. That's what bisagittal means on both sides, in order to adjust the position of the mandible without torquing the condyles. You want to keep the condyles kind of in home base and move the body and the rest of the mandible into a better position. Genioplasty is definitely the most conservative surgery of the list here. And all that is, I say all it is, but it's still a big deal. But all it is relatively is you're involving repositioning of the pagonian or the chin point by either sliding the chin, you basically make a cut through it and you slide it forward, slide it back, slide it up, slide it down. And it's making the chin more or less prominent. So if I were to think about it very simply, Lefort is for maxilla, moving the maxilla. BSSO is for moving the mandible. Genioplasty is for moving the chin. If we go back to the patient's appearance here, you guys can see a lot of things change after surgery. The occlusal cant changes drastically. The length of the ramus appears to change because things have been cut. And if anything, you can see all the hardware. So all these bone plates and bone screws you see underneath the orbits, around the nasal cavity, on the mandible as well. Nothing seems to be here up by the chin, but there's a lot of hardware on both the maxilla and the mandible. So all of you who said C are correct. This is a Lafort and a BSSO two jaw surgery in order to correct a very prominent facial asymmetry. All right. Any questions so far, guys? I think y'all are doing great. We'll move to the next one. If you have any questions, let me know. What's the most likely side effect of her orthognathic surgery? What was the most likely side effect of her orthognathic surgery? We either have A, infection, B, hemorrhage, C, nerve injury, or D, temporomandibular dysfunction. You guys can answer in the chat what you think it is, A, B, C, or D. Yeah, no implant there, Dr. Sarita. Okay, we have a lot of C's here. Everybody is saying nerve injury. That's fantastic. You guys are all correct. Great job. Great job. Everybody is saying C. A couple other ones, and that's okay. But C is absolutely the correct answer here. There has been a lot of published literature on this topic, essentially reviewing the different side effects associated with orthognathic surgery, because orthognathic surgery is a big deal. I'm an orthodontist, and sometimes, rarely, but sometimes a patient will present with a severe malocclusion that can only truly be addressed with surgery. And it's a big deal. Usually it's a last resort, not a first resort, but in some cases, it's the only resort to fully treat someone's skeletal malocclusion. And we talk about the different side effects that go into that. The oral surgeon, of course, will go into more detail than I do. But as part of the comprehensive treatment planning, I want to review with them what they're potentially signing up for, right? So these papers, one systematic review in particular, looked at 44 different papers and dissected the different results from it. Systematic review, of course. And from orthognathic surgery, they found that nerve injury was the highest complication at 50%, followed by TMD, temporomandibular dysfunction, at 14%. So those of you who said D were close. That was the second best answer. Hemorrhage was 9%. Hearing problems not listed here. That's 7%. Infection also 7%. And relapse was 4%. So that is the complication list. And nerve injury, as you guys said, was the most common. And keep in mind, nerve injury is actually a very broad category. So nerve injury can result in any neurosensory disturbance. It's not just, full anesthesia or numbness, right? Sometimes people get a BSSO and then they can't feel their lower lip and their chin. Sometimes the feeling comes back. Sometimes it never comes back. But it doesn't have to necessarily be that. Sometimes it's paresthesia, which is like tingling feeling, doesn't feel quite normal, loss of sensitivity. So it could be a lot of things, but nerve injury is the most common. Somebody mentioned this, Arpita, great job, one of my academy students. She said IAN injury, and that's absolutely true. The reason why it's so common, especially with BSSOs, is because the ramus cut is very close to the inferior alveolar nerve. So that's usually the nerve that gets injured there. So answer to this one is C. If you guys are curious, by the way, this is pulled straight from one of my live classes that I teach in the Mental Dental Academy. I'm going to leave the link for you guys if you want to sign up. We are doing a new live class, and we're doing it tomorrow. and it'll be 7 o'clock Eastern time. So same time as tonight, just 24 hours from now. How we do things in the academy is very similar to this, except you're actually able to unmute yourself and talk to me in real time. So if you have a question, like some of you are asking in the chat, I address that in real time. You also participate in the polls and the questions that I put up, and you can ask me questions at the end of class that have to do with anything that you're studying, whether it's for the INBDE or the ADAT or some other exam. And we have time to go through that as well. So those are really unique opportunities to interact with me one-on-one and to help you dial in your studying and to just be as confident as possible walking into the test so you know exactly what to expect. Okay, so that's mentaldental.com/academy. You guys can sign up for the monthly plan or the 3-month plan. And Mariana, does the academy design to study for ADAT too? Yes, it's designed for the ADAT. It's designed for both tests, and I have different tracks for both. So some videos are just for the ADAT users. I have a lot more on basic sciences, biochemistry, physiology, general and systemic pathology, more research heavy. And the INBDE has other things to focus on, more clinical sciences, ethics, things like that. Yeah, this is definitely real. This is definitely real. So we'll hide that for a moment. Let's go to the next question for the case. We're going to switch gears now, and we'll switch to pharmacology. What's the mechanism of action of her asthma inhaler? A, competitive inhibition of muscarinic receptors and bronchial smooth muscle, stimulation of beta-2 adrenergic receptors resulting in bronchodilation, inhibition of phosphodiesterase leading to increased cyclic AMP levels in smooth muscle, blockade of H1 histamine receptors reducing inflammation and bronchoconstriction. The asthma inhaler is right here. You guys can find that in the background and or patient history. That's albuterol. So with that information, go ahead and answer. Aura G asks, I'm doing the boot camp already. Is Academy different? Yes, it is. It's a completely different platform. I helped with boot camp, and I think they have an awesome platform. Great question bank and past prediction software. And of course, I talk about it a lot in my videos. The Academy is my own platform and the only place where you'll find live classes like this one, where I go through cases that are based on questions that appear frequently on the board exam, and particularly on these case-based scenarios that typically trip people up. Because if you get the first one wrong in a series of questions on the same patient, chances are the next ones you get aren't going to be any better. And so usually you either get most of them, all of them, hopefully, or you get none of them right. And that can really hurt someone's score. So that is the number one reason why I want all of you to sign up for the Mental Dental Academy. In addition to that, there are new videos that aren't on YouTube. There's handouts and lesson notes and mock exams and things that you won't find on YouTube either. But it's just a centralized resource that I created with everything, including these live classes. Yeah, thanks for asking it, Aura. Great job, guys. You all answered B, and this is wonderful because that is the correct answer here. Albuterol is a short-acting beta-2 adrenergic receptor agonist, which matches answer choice B beautifully. And what it does is it activates smooth muscle in the bronchioles, leading to increased intracellular cyclic AMP levels, and the muscles relax as a result of that, kind of opening up, bronchodilating, and helps it the patient helps make the breaths easier for the patient. Usually used in an emergency situation. If they get tight, they can't breathe, albuterol will open that up real quick. I'd love to ask, you guys are asking and participating really well in the chat. So I'll ask some follow-up questions here. Go ahead and answer in the chat what you think option, because all of these could potentially be used for different respiratory conditions. What do you think A, C, and D are referring to? They're each referring to a different medication. But what do you guys think? What do you guys think? A, what mechanism of action is that referring to? What is C referring to? And what is D referring to? And if you only know one, then you could just say the one you think. And if not, then we'll wait to see who does. Ferris asked, how long will I need the Academy subscription to be able to pass? I would say you want to be in the Academy for at least 3 months to get the bulk of the information learned. And so you're not rushing through everything and missing out on certain things. So most people they sometimes start with a month and then they say, oh my gosh, this is the most amazing thing ever. I'm going to stay subscribed. And they stay subscribed for 2, 3, 4, sometimes 6 months. It just depends on your study schedule, how much time you can devote to everything. And as we do these, we do the live classes every other week. So if you're a member for longer, you'll just get to attend more of those classes in person. Great question, Ferris. Glucose steroids, short-acting anticholinergic antihistamine, says Dr. Sarita and Rahima. You guys are working together well again, I see. So we'll start with D. That is an antihistamine description. And you guys definitely should know the mechanisms of action of certain medications that come up popularly on the exam. Antihistamines like diphenhydramine are common. That's what D is describing here. And so they're helpful to treat the symptoms of an allergic reaction, for example. Yep, I see some D, diphenhydramine, great job. Theophylline, good job, Arpita. That is what C is describing here. That's a phosphodiesterase, like theophylline. And cyclic AMP is definitely a distractor in there because it is in relation to albuterol as well, but different context. Inhibiting a phosphodiesterase is what theophylline does. And then A, not sure if anyone said, oh, anticholinergic. Great job. I see Dr. Sarita, you got it there. That is A, absolutely. Anticholinergic. An example would be, yeah, that's a tough one. Not used too often. Ipratropium. Try to say that 5 times fast. Ipratropium, that is an anticholinergic agent that can be used to help, but it is not what is described in this question. Albuterol is B. That is the perfect description of its mechanism of action. All right, very good. So that is the 4th question. Let's go to the 5th one. We'll switch to another topic of dentistry, this time a little more pathology related. You may have forgotten there's some white lesions on her buccal mucosa, and they were analyzed with a brush biopsy. The specimen contained civet bodies. From this information alone, which of the following is the definitive diagnosis? Candidiasis, linea alba, lichen planus, or hairy leukoplakia? And I certainly can pull up the patient box, but I will tell you all the information you need is right here. Great job. Yes, you guys are absolutely right. I talked about this in the Academy very recently, so I know you guys know this. This is great. Civet bodies, exactly what Dr. Arpita just said. Civet bodies and lichen planus are intimately related. So that's one of those things, if you see this on the board exam, you see civet bodies, you should immediately be thinking lichen planus. What they are, they're essentially these apoptotic or dead keratinocytes that appear on a histology slide. So if you're looking in a microscope, they're these rounded eosinophilic, so really red masses on a skin biopsy. And that's, of course, after you stain it with hematoxylin and eosin, the H&E stain, which makes things pink and red and purple and blue and all that. So there'll be big red circular clumps of dead skin cells, essentially. And they're most commonly seen in autoimmune conditions like lichen planus. Another example, you could see it in lupus as well, discoid lupus erythematosus specifically. Yep. Yeah, that's correct. That's exactly right. They're granules, and they're the result of dead keratinocytes. So that is question number 5. Answer is C for this one. Great job. And this could be, related or unrelated to what else the patient is going on here. But again, all the information you need is right here in the question stem. Very good. Okay, we'll go to the next question here. It's the last question. Question number 6, which of the following prescriptions would provide the most appropriate management for these white lesions that we just talked about? A, nystatin, B, clobetasol, C, acyclovir, or D, chlorhexidine? You guys can answer in the chat what you think. A, B, C, or D? I see some questions in the chat here too. Don't want to miss those. Dr. Sarita, is immune mediated instead of autoimmune? No, it's actually autoimmune. It's a T cell mediated immune response, where essentially the body's own immune system attacks the keratinocytes in either your skin, if it's dermal, or the mucous membranes. Hamika, sorry, did you mention that they can be seen in other disease? Yes, civet bodies can be seen in lupus as well. Discoid lupus erythematosus. Okay, we have some nystatins. We have some clobetasols. So it looks like we're split between A and B this time. So that's good. We get some discussion. Okay, so yeah, I see some responses in the chat talking about the different types of medications listed here. So we can rule out, we'll rule out C and D. And I like doing this too. When we have a board exam question where there's 4 answer choices, trying to get it down to 2 is always helpful. So trying to cross out at least 2 of these, get them out of the way, so we have a 50-50 shot, worst case scenario. And I feel pretty confident about getting rid of C and D. Acyclovir is an antiviral, so that would be used to treat something like herpes. Chlorhexidine is an antiseptic that would be used for something like gingivitis. Tries to reduce the bacterial load, reduce inflammation, swelling, bleeding, all things we don't want someone with gingivitis. So we can rule those out. They don't apply here. We're left with nystatin and clobetasol. Nystatin is an antifungal. Clobetasol is a corticosteroid. We were just talking about lichen planus. We were just talking about it being an autoimmune condition. If I had to pick between an antifungal and a corticosteroid, which of those two makes more sense to treat something that's autoimmune, that has to do with an immune system that is errantly attacking its own body? What do you guys think? Steroid or antifungal? Yeah, Himika, you're right. The steroid. Yeah, Salman, absolutely. We want a steroid that's going to reduce the effectiveness of the immune system. Sometimes that's bad. In this case, it's good because the immune system is acting awry. We don't want it to do what it's doing. And so it's going to calm down the inflammation and help manage the symptoms of this patient's oral lichen planus. So the answer to this question is B. A, nystatin would be better used as an antifungal for something like candidiasis, which is a fungal condition. All right. Well, that's it for the case, guys. You got a quick look at what these live classes look like. I hope you enjoyed it. I certainly did. I love doing these live interactive sessions with people. Again, this is something that we do routinely on the Mental Dental Academy. Link is now, I got to move my head a little bit. It's now down there. The Mental Dental Academy is my premium platform where I have lots of resources, including new videos that you haven't seen on YouTube, high yield handouts that I've personally curated, and they contain all the most important things. You can print them out, stick them on your fridge or around your office room or wherever you study. And then there are these live classes that we do every other week. Currently done 24 of them tomorrow, or 23 of them. Tomorrow will be our 24th class. So you add all that up, and that is a lot of practice questions right there. And they're all these case-based scenarios or research scenarios in the case of the ADAT. So there's a lot of stuff. If you're studying for the INBDE and or the ADAT, this is where I want you to be, because you'll be able to interact with me regularly. And then at the end of these classes, we usually wrap up in about 30 to 40 minutes like we did tonight. I'll have an open session Q&A where we go back and forth. And again, on the Academy, you're able to talk to me live with your microphone, which is sometimes a little bit more convenient. You can also type in the chat. Some people prefer that, and that's great too. But this is a great way to stay accountable, to stay on top of your studying, and then put yourself to the test in a live situation. It's low pressure, but it's also a little bit of pressure, right? Because we want to build that endurance and get you used to sitting down and actually answering questions and having to be accountable for the answers you select. What do you guys think, by the way? Let me know in the comments what you thought. Omar, thank you. You're welcome. Rahima, it was fun. I'm glad to hear that. That's awesome. Would love to have you join. All of you would love to have you join the Academy. Garamina, thanks. You're welcome. Isabella, you're the best. Thank you so much for this live. You're welcome. One more case, dog. Well, you can get another case tomorrow. We're doing a brand new one that no one has seen before, and that'll be in the Mental Dental Academy. Aura G, thank you very much. You're welcome. Ferris, what percentage of INBDE exam related to different topics? Yeah, there's a whole lot on pharmacology. There's a whole lot on ethics and pathology. A lot of the questions we talked about today, those types of questions, you can expect things like that, asking about mechanisms of action of certain medications, giving a diagnosis for a certain condition, what's the most likely one, being able to recognize a high yield oral pathology slash histology fact, like the civet bodies linked to lichen planus. Percentage, certainly, I actually have a document in the Academy in that very first lesson, if you enter in, with a breakdown sheet, and it highlights all the different topics, the subtopics, and then how many questions to expect from each of those. So you can look forward to that. I think you said you're planning on joining, Ferris, so that would be awesome. You could see it there when you join. Viviana, thanks a lot. Dr. Arpita, the live classes are great, sir, very informative. You're so welcome, and I'll see you tomorrow, I'm sure. Lots of thank yous. Guys, thank you so much. I'm so glad that this was fun and helpful and awesome. You guys are saying that's great. Lindsay, do we have live classes every day? I wish I could do every day, but we do every other week right now. And if you join, you'll have access to all 23 of the last live classes we've done. So if you did one a day, that would keep you busy for a long time. So there's a lot of these kind of classes that you can watch the recordings of, and always look forward to new ones that I'm doing every other week. Thanks, guys. This was a lot of fun. That's it for tonight. If you want to see me tomorrow again, we'll be doing the same thing, but with a brand new case on what I think is a great topic that's shown up a lot and also tends to trip people up a lot because they're not expecting it to show up. So we'll be doing that tomorrow, 7 o'clock Eastern time, not on YouTube, in the Mental Dental Academy. If you join, you will get an email tomorrow with information on how to access that course. As soon as you join, you are given access to all of the live classes as long as you're a member. So you will get access to the class, instructions on how to join the classroom. And I hope to see all of you there tomorrow. That would be great. But until next time, thanks again for everybody who joined. We had hundreds of people watching tonight, and that's awesome. Thanks so much for joining, everybody. And until next time, be safe, be healthy out there, and keep studying hard. And I'll see you in the next video. Bye, everybody.